Heart failure is a chronic clinical syndrome resulting from any structural or functional impairment to the heart's ventricular filling or ejection of blood. It occurs as cardiomyocytes gradually become stiff, weak, and damaged, and thus unable to pump adequate amounts of blood to meet the body's changing needs. Heart failure is not a diagnosis, but rather its etiology is a complex mix of symptoms stemming from the 5 following diseases. 1. Coronary artery disease. 2. Chronic hypertension, where the extra exertion over time leads to a stiffening of the myocardium and an inability to pump blood. 3. Valvular heart disease. 4. Cardiomyopathy, which is when the muscle becomes stretched and weak and thus unable to contract also. And then 5. Cardiac arrhythmias. Our bodies organically seek to maintain homeostasis using 3 compensatory mechanisms: increased sympathetic activity, renal retention of fluid, and tissue repair. But when these fail, so too does our heart, eventually being overworked, deprived of oxygen, and dying. This cyclic process repeats again and again until the heart can no longer contract. So Steve, tell me, how are you feeling today?
Not very good.
Patients with heart failure present with a wide variety of symptoms, most of which are non-specific, and thus difficult to accurately diagnose, especially while heart failure is in its early, asymptomatic stages. Symptoms patients present with include exercise intolerance and fatigue, dyspnea, which is exertional breathlessness, dizziness and confusion, as well as coughing and rapid weight gain. On examination, some clinical signs observed by healthcare practitioners may include cachexia, which is muscle wasting, crepitations and wheezing in the chest, a third heart sound, edema in the feet and ankles, hepatomegaly, and ascites, abdominal swelling. Heart failure has a mortality rate rivaling that of cancer, and within 5 years of diagnosis, 75% of patients will die of the condition. There are a sobering 270,000 Australians living with heart failure, and the AIHW states that on average there are 30,000 new admissions every year. More females have heart failure than males across all age ranges except the under 25s. In fact, almost double for most age groups. However, more males are hospitalised due to heart failure, as the disease is less recognised in women who develop symptoms at much later stages. And an estimated 1% of the Indigenous Australian population, about 4,500 people, have heart failure. That's 1.7 times as high at the rate as non-Indigenous Australians, and their rate of hospitalisation is almost 3 times higher. In a healthy heart, deoxygenated blood enters the right side of the heart from the systemic circulation by the vena cava into the right atrium. It then flows to the right ventricle, where it is pumped through the pulmonary arteries to the lungs. After reoxygenation, the pulmonary veins return the blood to the left atrium, and then the blood passes through the mitral valve and into the left ventricle before it is ejected via the aortic valve, into the aorta, and then to the body. Heart failure can be left-sided, right-sided, or both. In right-sided heart failure, which is the side responsible for pumping blood from the body to the lungs, there is a backup of blood in the right-hand side of the heart and the systemic veins, causing fluid to build up in our tissues, legs, and feet, known as edema. Left-sided heart failure occurs when the left ventricle, responsible for pumping blood around the body, loses its pumping ability, and so blood backs up in the large blood vessels of the lungs, known as pulmonary edema. This prevents adequate ventilation and symptomatically causes a shortness of breath, fatigue, and is termed congestive heart failure. Heart failure can also be classified as systolic or diastolic, where systolic heart failure indicates a pumping problem and an underlying disease may lead to the death of cardiomyocytes, for example coronary artery disease, where hard fatty plaques form and cardiac muscle becomes hypoxic and dies off. Valvular heart diseases and arrhythmias also lower the pumping efficiency, creating more work and thus more cell death. As the muscles are weakened compared to a healthy heart, the left ventricle can't contract as hard and there's negative ionotropy, which means less blood is ejected with each contraction. We measure pumping ability by the ejection fraction, which is the percentage of blood ejected in each beat. 55 to 70% is a normal range, however, below 40% can indicate heart failure. There's also diastolic failure, which indicates a filling problem where the body isn't receiving enough blood because the heart doesn't receive enough blood to pump out. Muscles are enlarged and the ventricles decrease in volume. This muscle hypertrophy may be due to chronic hypertension, where the heart is forced to gain muscle to push blood at an increased pressure through circulation in narrowed vessels. Or, fibrotic connective tissue may grow among dead muscle cells with low compliance and passive stretch, and thus there's less room to fill. In diastolic heart failure, the ejection fraction is preserved, which happens as even though the blood being ejected is lower, the end diastolic volume is also lower. To conclude, a failing heart does not abide by the Frank-Starling mechanism, which states that the more blood you squeeze into ventricles, the more forcefully they can contract. For each degree of stretch, only a lesser contraction is possible, synonymous to reduced cardiac performance, the definition of heart failure.